Super, good afternoon everyone. My name is John Lambourne, I'm an infectious diseases registrar at UCLH and the Hospital for Tropical Diseases, so thank you Samir for inviting me. I'd like to present an interesting case. My job this afternoon is to run to time and to try and keep you all entertained and stop you falling asleep, so bring your coffees back with you and hopefully I'll be able to keep you interested in a fantastic case. So what I'll do is I'll just talk through a case presentation which focuses a little bit on challenges in diagnosis and treatment. So without further ado, 66-year-old man with no significant past medical history travels to Cyprus where he's from. He's been resident in the UK for the past 40 years. Unfortunately, while on holiday in Cyprus, he develops left shoulder pain and has a spontaneous splenic rupture requiring an emergency splenectomy. While there, his peripheral white blood cell count is found to be over 100, and a bone marrow aspirate ultrasound confirms the diagnosis of chronic myelomonocytic leukemia. He returns to the UK and his white cell counts are well maintained on hydroxycarbamide, and he's worked up and scheduled for a reduced intensity conditioning sibling allogeneic bone marrow transplant at the end of January this year. However, events take their course and his disease changes in mid-January to AML. He starts ADE chemotherapy. His first cycle and second cycle are both complicated by Pseudomonas aeruginosa bacteremia, from which he recovers. However, pre-cycle 3, he develops a further fever, becomes drowsy and confused, develops respiratory and cardiovascular compromise and a diffuse macular-papular ash, all within the space of about 48 hours. So at this stage, obviously, his management is transferred to the intensive care unit. He started on broad-spectrum antimicrobial therapy. A full septic screen is undertaken and some imaging is performed. The imaging performed shows, this is a CT of his chest, it shows diffuse infiltrative change with some nodules and bilateral pleural effusions, so a clearly abnormal chest X-ray. And perhaps what best explains his neurological obtundation is an MRI of his head, which reveal these hypodense lesions within both basal ganglia, consistent with ischemia, with a report showing query ischemic change, possibly infective angiitis, or possibly involvement of his malignancy. His blood culture bottle in the aerobic bottle flags positive at about 28 hours. Now, this is not a great projection. These actually look a lot more blue. And a yeast is identified. So this is subcultured onto Sabro's agar, and white colonies grow at 24 hours. These are germ tube negative. The rest of his screen, his tracheal aspirate, no growth at 72 hours, and his skin lesions were not biopsied. So this is the first question. You've got a man who's clearly septic, immunocompromised on ITU, and you've got a germ tube negative yeast in the blood culture. So what would you do? Start fluconazole, start anakinda, amphotericin, voriconazole, or something else. Very good, fantastic. So we've got a query non-albicans candida growing in the blood cultures. Let's start anakinda, fantastic. So moving on to the next slide. Interestingly, his blood culture was identified on the Vitek as something called Geotrichum capitatum, and on the MALDI, it's identified as Magnesiomyces capitatus with a good MALDI score, and the fluconazole E-test was identified to be resistant, and the isolate was duly dispatched to the mycology reference laboratory. Interestingly, he was started on the basis of that on voriconazole, and his repeat blood cultures remained sterile 48 hours later. His lumbar puncture performed 48 hours into therapy, showed a leukocytosis, which was polyclonal on immunohistochemistry, suggesting this wasn't a malignant infiltration. So what to do now? You've got something that's identified that you probably don't know the name of. So you've got Magnesiomyces capitatus in the blood cultures. So what would you do now? I think the last one is the one that most people will do. And I think phone a friend particularly means the PhD mycology reference laboratory, as opposed to consulting Dr. Google. So exactly, a nice spread. So amphotericin, anakinda, voriconazole, combination therapy, phone a friend. So a nice spread across the cases. So let's move on to the next slide. So what happened? Interestingly, his sepsis settled. He went on to develop a large pericardial effusion that was sterile, although, as you might imagine, given the extent of his neurological lesions, he remained neurologically obtunded. Decision was made not to continue treatment for his hematological malignancy, and he died 30 days after the first positive culture. So, an interesting but slightly unfortunate case, but let's have a bit of a chat about what on earth is Magnesiomyces capitatus. Well, as you've seen, it's a yeast. It's one that's widely distributed within the environment, including wood and soil and dairy products, but also can be part of the normal human microbiome, isolated from skin, respiratory and gastrointestinal samples. It's, given the title of the talk, is what's in a name. It's an organism that's known by a variety of names. Why, other than just to be perverse, will I show you all these things? It's important because different identification mechanisms will give things different names. The Vitek called it a geotrichum. The Moldy called it a Magnesiomyces. Its current term of preference is Blastocysomyces. The importance of this is that if you don't know they're the same thing, you may well miss the presence of a cluster. And it also means that when you're trying to prepare a talk, it means you've got to search for all these terms on PubMed to try and work out what on earth it is. And it's closely related to these species down here. So what is it? It's an infrequent cause of invasive fungal disease. Talking to Liz Johnson, they receive less than 10 isolates a year of this through the Mycology Reference Laboratory. It's commonly identified in blood cultures when it's found, but also causes a disease not dissimilar to disseminated candidiasis involving lungs, skin, CNS, liver and spleen, and autopsy findings suggest it has a capacity for angioinvasion. The major risk factors in studies, more than 75% of patients fall into people who have received their induction chemotherapy for acute leukemias. There does appear to be some geographic/climatic risk, most cases reported from the Mediterranean, particularly from Spain. It's not particularly clear why that is. It's an organism that can grow at relatively high temperatures, or whether as more an environmental burden isn't clear. So how do you identify it? It grows very well on most fungal media, including sabros. And the important thing is early, it looks very yeast-like. It looks very much like a candida, dome-coloured, cream-coloured colonies. And on microscopic examination, you need to see three different types of canidia. So this is just a picture of the 24-hour growth on sabros agar, which I'm sure you can see looks very candida-like in terms of nice cream dome colonies. This is it under higher power magnification from a strip of a colony, and you can see true hyphae with branching. The hyphae fragment to form these rectangular structures, but also you can see you have these ovoid bodies here. So you need all these different forms in order to get your diagnosis, and thanks to Dr. Fungus for the picture. So how is it identified beyond microscopic and macroscopic examination? You can do biochemical tests, and the Vitek really has no problem in identifying it. You can do mass spectrometry, and you can do sequencing. Again, caution that different tests may give you different names. Susceptibility profile, I'll jump to the second point. It is intrinsically resistant to the echinocandins. So, important take-home message, it looks like a candida, but it's intrinsically resistant to the echinocandins is really the main point of this case. Given the rarity of cases, there's really no great data about susceptibility breakpoints. And as we've already heard, your MICs may vary depending on the testing strategies you use, whether you use CLSI, microdilution, or whether you use e-tests. Usually, amphotericin, flucytosine, voriconazole, and prosaconazole are usually active. As with most invasive fungal disease, the strongest predictors of survival are recovery of neutrophil function and or neutrophil number, and the overall mortality from small case series that have been reported approaches 60%. So the learning points from this case really are just beware germ tube negative yeasts before you call them out as non-albicans candida in the immunocompromised, and always think about putting them onto a Vitek or a Moldy to get a name before you reach and rely on your echinocandin. It would be a slightly dull story if I was to stop there. So this isn't quite the full story. I will continue briskly through. So, okay. I've been told I have enough time. So there we go, very good. So I will slow down and stop rambling, stop flying through my slides. So case number 2, Mr. PE, again AML, transferred from his local hospital to UCLH for induction chemotherapy, which was initial cycles complicated by perineal infection and disease that proves refractory. So he moves on to have FLAG-IDA, so intensifies his chemotherapy in May of this year. However, in mid-May, following his first round of FLAG-IDA, he develops respiratory deterioration and a diffuse maculopapular rash, very similar in appearance to the first case. His blood cultures, you can spot the trend, flag positive in the aerobic bottle at about 22 hours. The gram stain shows yeasts, and it's germ tube negative, and he started on kappa fungal. Thinking that this is a non-albicans yeast. So this is what, after that, the Vitek calls it a geotrichum, the Maldi calls it a Magnesiomyces. It gets sent to the reference laboratory, and they again say, yes, you're correct. It's another Magnesiomyces capitatus. He has a skin biopsy, which, again, culture and histology confirm Magnesiomyces capitatus. Unfortunately, I haven't got any pictures of that skin biopsy in this talk to show you. And his CT scan also suggests a fungal chest. So this is his CT scan. So a bit more subtle than the last one, but I think you can appreciate diffuse reticular nodular shadowing throughout both lung fields with some larger, more peripheral nodules. So his progress is slightly more cheery in that he's given a month's worth of ambisome, flucytosine, and voriconazole. He recovers his neutrophils and perhaps therefore recovers clinically. In July, he goes on for further chemotherapy. August, he has a SIB-allo transplant, and in January this year, he is well and off of any antifungals. So, possibly just a coincidence. Possibly not. Case number 3. Moving on, this is Mr. DT, who has primary refractory diffuse large B-cell lymphoma. I won't go through this, but you can see extensively pre-treated in the 18 months or so before he comes in for an attempt at a mini-leam with a view to a salvage transplant. So he has his mini-leam, but unfortunately prior to any transplant, shortly after his initial mini-leam, he again has febrile neutropenia, refractory hypertension, and then down to ITU. So spot the pattern, his blood cultures flag positive in the aerobic bottle at 30 hours, yeast seen, germ tube negative, Vitek calls it geotrichum, Maldi calls it Magnesiomyces capitatus. Interestingly, his CT abdo and pelvis is suspicious for hepatic, not hepatic, splenic and renal abscesses. So these are some pictures. So I think you can see multiple kind of abscesses in liver, in spleen, in kidneys, and in kidneys. So as perhaps might be predicted, he doesn't do quite so well. So started an ambisome and flucytosine, but unfortunately dies of overwhelming sepsis 72 hours after the first positive blood culture. Just when you thought 3 were not quite enough, we get a phone call, unfortunately, after his demise, saying, do you know that odd candida you sent to us from the respiratory tract of a patient with a candida that you couldn't identify? Actually, we've identified it as a Magnesiomyces capitatus. And this turns out to be a patient who had lung cancer, but who was admitted to the same ward. And when we go through the timeline, his initial isolate predates all 3 subsequent cases. So, Magnesiomyces cases 1's unusual, 2 is really unusual, 4's an outbreak. So time to take this very seriously. So, next question, what would you do now? Panic a little, panic a lot. Outbreak meetings, send for typing, screen everybody, screen everything, treat everything, change your empiric therapy, or all of the above. So voting, please, for what you would like to do. So let's have a look at the results and see. Marvellous, very good, well done. Very good, I agree. So everyone's going to, I'm glad most of you are going to panic a little bit, so I know that was definitely the feeling. So moving on to the next slide, if we can. So let's have a bit of a think. Looking back, what do you do in this sort of situation? We ended up looking to say, well, who else has described this? Where else has this occurred? What happens with Magnesiomyces outbreaks? Who's seen it before? There are very few case reports. There's a cluster of 4 cases in a Spanish BMT unit that arose over a much shorter time period, over 15 days. Interestingly, they found the isolates cultured from flasks used to store and distribute milk on the ward. When they found the isolates, they typed them, They found that the isolates from patients in the environment were indistinguishable. Milk flasks were removed. No further cases were described. A second outbreak that's recently occurred in this ongoing investigation in French bone marrow transplant units, 30 cases across 10 different units, widespread across the geography of France, involving a relatively similar related organism. The isolates were typed using whole genome sequencing, and the ongoing investigation suggests these were possibly infusion-related cases related to a device used for the storage and infusion of apheresis platelet concentrates. But the investigation is ongoing, and this is recent. This is from a few months ago. So we really need to think about the possibility of ingested, possibly inhaled, or possibly injected source of these. So what did we do? The infection control investigation firstly confirmed that this really was a true investigation. So the reference lab helped us hugely in that by confirming that yes, all the isolates were Magnesiomyces capitatus. All of them had very similar sensitivity profiles with only a single kind of dilution either side on most of them. No typing was done, and the identification that's used genetically tends to focus on a very conserved area of the genome, so we didn't do whole genome sequencing or use VNTR or anything like that. So confirming the isolate did really take place. Then we looked at the timeline and the geography of the outbreak. Then we went into the environment to try and see if we could find it. And then steps were taken to try and control the outbreak. So just look at the top bit first. This is just the timeline. So these are the cases as I presented them in order. So case number 1 was in April, when the first sample. Case number 2 is in May. Case number 3 is in June. And then the retrospective case predates all of these in terms of the first isolate was back on April the 1st. So I think the key thing in contrast to the French study, this is an outbreak with clusters that have occurred over quite a protracted period of time. And if you imagine UCLH has a very busy transplant hemonc unit, many patients will have been on the unit throughout this time with similar, if not more severe, immunocompromise and didn't succumb to Magnesiomyces infection. So what was it that these cases can have had? And this is just to show that the susceptibility pattern for most of them was the same, again suggesting that this was a shared outbreak. This is the geography, so this is a projection of the floor plan of the ward. And so this is in terms of chronological order. So case number 1 was the case that was identified last, up at one end of the ward. Case number 4, case number 2, case number 3, ward kitchens, ward beverage bays, the entrance to the ward. So I think you can see that there's no, although they're all on the same ward, there's no easy clustering at one end of the ward. So this doesn't really suggest a single, perhaps kind of ventilation failure issue or a particular kind of, tap or a source related to the fabric of the building. The interesting thing is all patients were on the same ward, which does imply a shared source. As I said, dispersed in time, and many patients who didn't succumb. So moving on to the infection control investigation, lots of things were looked at, lots of things were photographed, lots of things were swabbed. So just looking at some of the pictures, they came across these findings. So this is the fridge that was, this was the patient fridge. So the fridge that was used to store patient food and drink. This is a close-up of the flask used to store milk used to make some of the hot beverages. And this is a great infection control slide. So what is wrong with this picture? There is a lot wrong with this picture. So radio splashed in what we're told is ambisome, but I'm not so sure. And so close to the hand dispenser that there's no way you could reach the alcohol dispenser using that. So the other issue that came out was that looking at food preparation was that a lot of the patients were nutritionally deplete and had build-up milkshakes prepared. These were prepared not by the catering staff in the kitchens of the hospital under aseptic conditions, but were prepared by volunteers on the ward and would use the same milk jug for preparation and take it around to all the patients on the hemonc unit. So lots of potential sources. Unfortunately, no smoking gun was found, so lots of swabs were sent, lots of sand plates were set up. Magnesiomyces wasn't found. We did find some aspergillus on a wooden spoon in the kitchen, and some VRE was found, not surprisingly perhaps, on the end of that milk jug. So, as you can see, issues were found with environmental cleanliness, food and drink storage, food and drink preparation. So, as with most infection control investigations and interventions, there were multiple interventions that followed, including enhanced cleaning, storage, preparation, a look at aseptic technique in the prep room, and getting some new equipment. I'm not sure whether the new equipment was a new stereo that had less ambosome on the front of it, or whether this is new trays. So I'm pleased to say no further cases in the last 6 months. It's a ... So we just need to see that the last case was 6 months ago, so we need to watch this space just to see. So last question for you all. So where do you think the Magnetomyces came from? Just to wake you all up before I finish. So let's have a think. Did it come from the milk? Did it come from an infused product? Did it come from the platelets? Did it come from the air? Did it come from the patient's own flora? So had they all kind of come in with it and they were neutropenic and they got some gut translocation? Or are the cases unrelated? This is just stochastic events, or has it come from somewhere else? So please vote now and let's see what you think. Let's have a look at the answers. Oh, very good. Okay, very good. So the milk we suspect, and things have changed. So I think in terms of conclusions, these are the take-home messages that we learned was beware germ tube negative yeast in the hemonc cohort, push for an accurate diagnosis. Echinocandins are not a panacea for all yeasts. The real benefit of early involvement with the reference lab, that was the starting point for our infection control investigation, was knowing that there was an outbreak and was getting the reliable identification from reference laboratory, and just the importance of a timely, coordinated infection control response. So some really interesting cases. It just remains me to thank Sonia, who's one of the microbiology registrars at UCH, who's done a lot of work on this, John Swanson, infection control, Andrew Ward, BMS, Steve and Vanya, two of the consultants at the UCH, Liz Johnson, who helped me with the reference lab data, Samir for the invitation, and you all for voting and for listening, and for most of you staying awake. Thank you very much indeed.